are going to launch a new version of our mobile application. And whenever we do clinical practice, we are often challenged with scenarios where we don't remember everything, we don't understand the approach, and we don't understand the figures. We want to use some calculator, and it's very difficult to do it on a day-to-day basis. Now, I always thought that when you are managing a case, like a challenging case comes to you, let's say of a persistent hyperinsulinism, the conventional approach is that you go back to the books, start reading from there, try to get back, and then decide how to manage. The problem of this approach is that most of the time you'll start off with pathophysiology, then you will go on to what are the causes, then you will go to evaluation. So by the time you reach to the management, it becomes difficult. So what we have been trying to do and what we have been thinking for over a decade is to bring those algorithms that have been developed into real practice, which make it very easy and to do it on a point of care fashion. These are relevant predominantly for people who have less exposure in pediatric endocrinology, but also helpful for everybody. So if you're using it and you're sure that this is the way it should go in a precise manner, the applications will help out. So we started around 5 years ago, and today we're going to start off with many new formats of these interpreters, which will allow us immediate evaluation and management on that perspective. So over the next 2 hours or so, we are going to really highlight how these solutions can help out in terms of our day-to-day pediatric endocrine care. Now, why we started thinking of developing these tools was this case, whom I managed when I came back immediately, maybe 15, 16 years ago, was this 7-year-old boy with short stature who came to us at a time when nothing could be done, in that the bones were fused. Now, this is not unusual. Still, 10 to 15% children come to us at a very late stage. What was unfortunate in this case was that he had all the features of celiac disease. He was TTG positive, but unfortunately, because of the severe anemia he had, that was maybe around 5 to 6 years ago, he was evaluated by a pediatrician who advised blood transfusion, which culminated into HIV/AIDS. So a reversible thing, a very simple thing like celiac disease turned out to be in a very adverse scenario. And that made us think what could have gone wrong and how could we have improved in that regards. So the most important thing in terms of the improvement of care of any particular individual with a health disorder is awareness. If the patient is aware at the right time when to go to the doctor, if the doctor is aware what things to order, how to evaluate, we can prevent most of the things. Accessibility to specialists is number two. Affordability is last. So often people think of pediatric endocrinology that you need very expensive investigations in a very complicated scenario, which is not true. If you do it at the right time, you can identify in that regards. Now, how do we really have a true evidence-based clinical practice? For that, there are multiple things that we need to implement. Of course, there are a large amount of books which are available. You have to put all that knowledge back into clinical practice. This involves ordering rational tests, especially in resource-poor settings where you can't just order every test all the time. You have to use that in terms of algorithms. You have to understand about the various drugs, the interaction, how to use, what dose to use, and then finally you have to take everything up to make that. So the process of a rational management of a child with endocrine disorders, of any child, requires a comprehensive combination of diagnostic, therapeutics, approach, management. All this perspective is important. So we tried to build up resources which will help us in terms of overall improvement of pediatric endocrine care initially in the country, and then beyond that. So we started with workshops. So we have conducted over 200 workshops across the country. But that itself is a very tedious process, and the retention of people is not a long time. So they will forget. Maybe once you do a workshop, 1 week later, everything is gone because they're not implementing in the clinical practice. We started with practical courses. So 15 courses have been done in the country, but they are extremely resource intensive. You would need a lot of time, energy, money, everything. So it's not easily feasible. We started with our YouTube program, which provides a lot of free channels. So this is also there. We started an on-site fellowship. So till now, we have 14 fellows who have joined. So this is something. But then again, the reach is limited. To take it forward, we started with our Medi classes, which was our online portal, which takes it beyond the routine classroom to beyond, so that people can use that knowledge and understand in a systematic fashion, brought up the textbooks. But then at the end of it, what we realize is that unless and until we have something in the hands of a physician at the time of management, they would not be able to take the implement all this knowledge, because knowledge is there. Unless you see it day in and out, then it's in your reflex. Otherwise, you will forget. So then we thought 5 years ago to develop a mobile application, which at that time was a unique way of managing cases, and still now it is one of the very rare ones in that perspective. So as I said, we have done a lot of pediatrician initiatives across India and abroad, including a lot of workshops, practical courses, advanced courses in that perspective. Our e-learning portal has got huge number of videos and a lot of watch time. We have organized learning, which is a validated program at learning.growsociety.in, which offers courses for pediatric endocrinology to various aspects, starting from the fellowship program to small fragmented courses in that regards. And these have been accessed from people across the globe, which has culminated in that. We have got 3 publications, both basic, advanced, and protocols, which form the basis of many of these applications. So all these algorithms that we use now are largely based upon many guidelines plus clinical experience, and many of these are already published in these books. So we have used that to translate these books right away for clinical management. So the Mediclasses Endocrinology was the app which was basically released around 5 years ago. It is the most downloaded pediatric endocrinology app, or an endocrinology app, so to speak, with 10,000 installs. There are multiple places where it has been presented, multiple awards have been given. There are publications also which have come out from there. Now, the crux of this app is to try to translate what knowledge is in terms of clinical practice. So the most important ones we started off were approach pathways. Now, how these approach pathways were working were like these flowcharts. So there will be questions which people will answer, and based upon those question answer, we would be able to achieve the diagnosis in that perspective. And this is how you will read. So based upon your results, the next question will come up, and then subsequent to that, a final diagnosis will come up. So this was a stepwise approach. It simplified the algorithm. Now, if you have, let's say, algorithm pasted in front of you also, it may be more difficult, but if you get precise answers, it made it much easier in that regard. So there are covering entire parts of pediatric endocrinology in the approach pathway. There are management pathways similarly, because many of these scenarios, like if you think of increased insulin effect, how do you decide which workup to do, what to do? So we developed these management pathways. This allows implementation of algorithmic approaches and management on a clinical basis. So it gives you a personalized guidance. Now, the problem with these pathways is, which I don't think it's a problem, it's part of their way they have been developed, is that it will take a bit more time and you will have to put inputs every time. This is an advantage also, because then you can get a much more detailed picture of the clinical scenario. But often in this day and age, we want instantaneous results, that we want immediately that you input the data and you get the output. So for that, what we tried to develop was interpreters. And one of these interpreters is like thyroid interpreter, which Dr. Vibha will talk a bit more, in which what you do is that you just enter your analysis, and based upon that, you will get the diagnosis as to what you're dealing with. We have now largely taken forward a number of interpreters, and this time which we are going to launch is interpreters which are holistic approaches for complete electrolyte disorders in a single interpreter, hypoglycemia, calcium, and these interpreters have become, they are instantaneously more helpful because they give immediate results. But we need to remember is that because they are based upon one-time input, they may not be as encompassing as compared to a approach pathway. So often if somebody uses that, like here what it says, follow approach pathway as well. So this is for the initial guidance, and then you can go ahead and use the approach pathway from that perspective. Now, of course, when you say that you do a particular test, let's say a AMH test, you need to understand when to do the test, how to do the test. So you don't want to go back to the book and open it up. We have a full diagnostic section which provides what is the timing, what is the sample type, what is the reference range, and everything is available within the app. So within a single app, you've got all the information. Similarly, if you want to prescribe a drug, there is a therapeutic section which really provides the detailed information. So all the drugs which are used in pediatric endocrinology are there, and we give all the adverse effects, interaction, and all those parts in that regards. Many times in pediatric endocrinology and other aspects, you want instantaneous calculation of things. And this is something which we have provided. And this is not only simple calculator, it is also helping us in scoring system. So like external masculinization score, often people will forget. Those who are not using it regularly won't remember. So here you will get what exactly you have to input and you will get the result. Similarly, bone age, this was a Achilles heel for pediatricians. So this was a major development which we did in terms of developing a bone age tool which uses only 5 sites to provide an accurate estimation of bone age, which can be done rapidly even via a non-expert. So this is something which has been used now across the globe. This has been published and validated, and we are going to make it even more simpler, hopefully soon. And things like Ferriman-Gallwey score, which may not be possible for the patient to examine right in the clinic, we can ask the patient to self-rate and they will give you a picture. So this is going to help you provide an objective estimate of clinical parameters. Now, many people say, okay, we now have a pathway, we now have interpreter, but we want to learn a lot. Now, what we have done is that entire knowledge bank, which is there in our website, is provided here as well. So if you want to read a particular thing without the figures, otherwise the load will become too big. The app will become a lot of GBs there. You have got all the textual information you can read about any particular condition. So entire knowledge pathway is there, and you can also test your knowledge using the mobile pathways in which questions are there, which scenarios can be used. So what we have tried to do is to bridge all the things, including diagnostics, therapeutics, approach, analytics, to get the clinical management based upon the latest state-of-the-art guidelines from that perspective. And this is something which we wanted to do. So a lot of awards have been given. So in 2019, we had the presentation as far as the bone age interpreter is concerned. Dr. Riddhi had presented that and won 2 awards, one from the IAP Research Conference and the Indian Society of Pediatric Endocrinology in 2019. Dr. Sayan won the award and the West Bengal IAP in 2022 regarding puberty interpreter. Then we had a good presentation on bone age in the novel tool used by Dr. Naveen at the Asia Pacific Pediatric Endocrine Society conference in Seoul. Dr. Vibha has been presenting many of these ones, including in the American Thyroid Association, including the thyroid interpreter. Then we had Dr. Alapan, who presented the diabetes interpreter at the Asia Pacific conference. Dr. Dhwani, who won the DSD interpreter. So a lot of publications have come out from there, including the growth chart, the DKA management, and the bone age assessment, and many more are on the way. So what we're going to do today is to try to cover a wide variety of pediatric endocrinology and how our tools can help us.
10-year-old boy presented with osmotic symptoms of polyuria. Blood sugar is high with a high HbA1c of 10%. She landed up into ICU with DKA and required insulin in that scenario. But the treating physician has found that the child is obese. He has family history of type 2 diabetes in his family, and some signs of acanthosis nigricans in terms of insulin resistance were there. So he considered this child as a case of type 2. He stopped insulin and advised child the metformin in that scenario.
Do you agree with this? You think now a lot of patients who are obese, have acanthosis, have this diabetes. Do you think he's right? And can DK happen in type 2 first of all?
Yes, DK can happen. 5 to 10% patient with type 2.
Do you think he was right?
I think before considering or labeling someone as type 2 diabetes, we should always look for the antibody status in the child. Ideally, 2 antibodies should be present to call it a type 1. If antibody is negative, then we can consider for the type 2 diabetes in this scenario.
Yeah.
So look at the guidelines, what ISPAD has said in 2022, that if even the symptoms of hyperglycemia and values more than 126 of fasting, 2 hours more than 200 and HbA1c of 6.5, if you have to consider for a islet cell autoantibody, if islet cell autoantibody is negative, then only you can say this is a case of type 2. Otherwise, you have to always consider for the type 1 diabetes.
So this is the very important. The default diagnosis in pediatric diabetes, even in this day and age, is type 1 diabetes. If you are antibody negative with low requirement, then think of type 2 or MODY in that perspective. In our experience, how many are type 1? What percentage of 10 to 18 will be type 1 versus type 2?
Almost, sir, 75 to 80% will be there in type 1.
Even between 10 to 18, around 75% will still be type 1 diabetes. And do you see obese type 1 as well?
Yes, we used to see a lot of obese children because the lifestyle modifications were not there even in the type 1.
So this obesity is not a very important criteria for type 1.
So as we move forward in this case, the child was GAT positive. So eventually a case of type 1 diagnosis, type 1 diabetes, which was mislabeled as type 2 diabetes. So we often see this case kind of misclassification in our practice where type 2 are labeled as type 1 or type 1 was labeled type 2. So insulin was further continued in this case. So type 1 diabetes, it is very common in children population, and almost 80% cases among all the diabetes population are type 1. Type 2 is see in 15% cases, and rest of the cases are MODY or other genetic causes of diabetes they are present. So a child with type 1 diabetes, when to consider that this could be another possibility of MODY or another kind of diabetes. So if in a case of diagnosis, in a case of type 1 diabetes, if there is no insulin need, even after 1 year of diagnosis, the C-peptide level is detectable. There is a family history of diabetes in the patients, and the first degree, at least 3 generations were positive for diabetes, and there is a negative antibody, then we should consider for the other diagnosis like MODY in a case of type 1 diabetes. At the same time, a diagnosis of type 2 diabetes, if there is no obesity, no acanthosis present, we should always consider for the other kind of diabetes. And as already sir has discussed that calling a patient as type 2, you should always have a negative islet cell autoantibody. So if we classify three types of diabetes, the type 1 diabetes can present at any age, but it is usually, we have seen the peak age is around 5 to 15 years of age, while the type 2 we often see around the pubertal age after 10 years of age or something like that, and MODY can present even before pubertal age or after the pubertal age. If we consider the family history, the type 1 doesn't have that much family history, but there is a strong family history in cases of monogenic diabetes, maturity onset diabetes of young, where almost 3 generations of are affected in diabetes. In if I see from the obesity perspective, the type 2's diabetics are much more obese, but the type 1 MODY and MODY can be also obese, but it doesn't has a percentage because it is almost equivalent to the population prevalence. The severity, if you can see, the type 1 has much severe cause, can land up into type 1, but any patient coming to decay in our ICU setup, we should not label them as type 1, as some cases of MODY and type 2 can also have diabetic ketoacidosis. Ketosis is usually present in cases of type 1, and autoimmunity is almost a diagnostic of type 1 diabetes, but some cases are there where 10 to 20% cases of type 1 could have a negative autoantibody screening, while some MODY and type 2 have autoantibody positive screening. There are some HLA associations that are common in cases of type 1 diabetes. And if we go for the fasting C-peptide level, which is a marker for insulin reserve in our body, we can see the type 2 has much more insulin reserve in comparison to the type 1 and the monogenic diabetes. So there are some autoimmune type 2 diabetes are there where there is low beta cell reserve, and there are features of less metabolic features like no obesity, less signs of insulin resistance are present, and there is a need for insulin in this child.
If you have suppose labeled somebody as type 2 and there is a associated antibody which is there, will you treat him like type 1 or type 2?
We have to see for the course as well as the severity of the diabetes.
So even if the antibody is positive, will you still consider type?
No, it can be, sir. It can be
LADA
type of presentation.
Then you manage it like type 1,
type 1
basically.
Yes. So so there is a need for a point of care tool which will correctly classify diabetes, because the improper classification often lead to missing of type 1 decay like presentation, which can land up the child into ICU. So our application is based on this algorithm, which is taken from the SPAT 2022 guidelines. In these guidelines, we have seen that if the child is below 6 months of age, we consider genetic study and we consider them as a neonatal diabetes. In the age group of 6 to 12 months, if antibody is positive, then only we consider this child having a type 1 diabetes. In age group more than 10 years, if a child does not have any decay, is an overweight child and a negative autoantibody, then only we can consider for a type 2 diabetes. Otherwise, when the insulin requirement is less than 0.5 after 1 year of diagnosis with a negative autoantibody screen, we can consider monogenic diabetes. Rest all we'll have to consider type 1. We have to manage like type 1 because we don't want to miss out the diabetic ketoacidosis in children.
So the interpreter basically is looking at age at onset, duration of diabetes, how much insulin need is there, and what is your BMI. Just four things. And then based upon four things, we are trying to classify. So we need to understand that there will of course be some limitation, that if you have some syndromic features that you have to see examine, if you have some other specific features of secondary diabetes as we were discussing, I is going to be difficult. But if you want to have a ballpark figure, by using just four parameters, we are able to classify. Like in obesity interpreter, we talked about BMI, we talked about height, growth, development, and vision. And then we try to classify. So same is the diabetes interpreter. So how does it work and what have you found in your validation study?
Yes. So based on this, we have developed the app of diabetes interpreter and validated it. It is a mobile application based tool. We have seen it has a higher concordance with the gold standard. Gold standard is a senior pediatric endocrinologist having experienced more than 25 years of age. And we see the gold standard and the diabetes interpreter has a concordant rate, as well as the pediatric and adult endocrinologist have a similar kind of concordance rate in terms of diagnosis as well as suggestion. While in comparison to them, the pediatric trainee and the pediatrician have a much lesser concordance score in terms of diagnosis as well as the recommendation. So if we can see from here, the pediatrician and the pediatric trainee has advised for workup when it was not needed in 42% and 43% cases, which was much higher in comparison to the diabetes interpreter as well as the pediatric endocrinologist. So we can see a lots of unnecessary workups there has been advised, and this workup increases the cost of burden in the families of the type 1 diabetes, and we want that to decrease that cost. Not only that, there is also some misclassifications that are present. We can see the adult endocrinologist had diagnosed 30 cases of autoimmunity, almost 4.97% cases, without advising autoimmunity in that, diagnosed type 2. So in these scenarios also, as ISPAD had clearly mentioned, that before labeling someone as type 2, we should always consider for the default mode, that type 1, and we should consider for the genetics autoimmunity screening. Not only that, if we see from the type 2 perspective, we can see the adult endocrinologist had correctly diagnosed most of the cases of type 2 diabetes in comparison to the pediatric endocrinologist and the trainees. So the adult endocrinologist who is expert in type 2 is diagnosing more cases of type 2, while he is not doing GAD antibody in suspected cases of type 2. So here lies the importance of our application in the clinical practice, where the application could correctly guide you regarding the diagnosis. Not only it will recommend the treatment where the workup is needed and where it was not needed. So if we see our case, which are previously discussed, a child with 16-year-old polyuria having a blood sugar of 440 and HbA1c of 10%, initially admitted as DKA and having a BMI of 2.2, that is in obese group, now requiring 10 units of insulin per day. If we see our interpreter, let's see what it gives. So it has recommended in its first line that recommend GAD antibody. Before labeling someone, please recommend a GAD antibody. If GAD antibody is present, then we can consider for the type 1. Otherwise, it could be a case of type 2.
Which you're looking at is this is more than 10 years of age. Follow-up duration is more than 1 year.
Yes.
And the insulin dose is less than 0.5. So this means that this is an insulin replete individual who is obese. So now clinically you will think of type 2 diabetes as a possibility. But yes, as Alapan has illustrated, GAD or any autoimmunity should be assessed in that regards.
So moving on to the next case, 11-year-old girl, routine investigation were done and seen the fasting is on the pre-diabetes range, and postprandial range was also in the pre-diabetic range. She has a lean thin individual and BMI of 19.2 with no features of insulin resistance present. HbA1c is on the borderline, again 6.4 with no ketosis.
So what do you think, Alapan, in a lean child who comes to you with this sort of a picture, pre-pubertal child, whose fasting is reasonably high, postparental is not very high? Do you think this is type 1, type 2?
Sir, Sir, unlikely this case is a type 1 because the fasting level is high and the postprandial is not high. Doesn't have that much signs of any other insulin resistance or so clearly the type 2 perspective is out.
So type 2 is extremely unlikely.
Unlikely.
Type 1, you can say, okay, this may be a very early diagnosis of pre-diabetes you have diagnosed. But what is more likely? If you think of this biochemical picture.
This is more likely a case of monogenic diabetes, especially GCK defects, because the fasting levels are higher in this scenario in comparison to the postprandial levels.
So your glucokinase is not working if you have basically a fasting level, and once the levels go high, they start working. So that's why this delta increment is much lower in that regard. So let's put on the app then.
So she was GAD negative and see what our application gives in this scenario.
So this is saying recommend GAD antibody and targeted panel for MODI if negative. Now this you can also get if you take a good clear history that the mother also has a similar pattern, maternal aunts also had the problem in this girl. So this is there. So if you are expert, you can judge it. But if you're doing your routine and not seeing that many patients, you may miss it out. That is the message from there. This turned out to be a glucokinase defect.
Yes. So moving on to the next case, a 2-month-old boy presented with failure to thrive. Birth weight was initially 2.5 kg. Now it's 2.8 kg. He has hepatomegaly, myopathy, weakness. Blood sugar is sky high, 487 with HbA1c of 9.9 and high TG level. So he was advised glargine, a long acting, and lispro, a short acting insulin in that scenario. So let's see what our application gives in this regard.
So what do you think according to you?
This is a 2-month-old child, so neonatal diabetes should be a consideration in this scenario. We should look for a genetic study.
You have to think of a targeted panel clearly in this scenario. Now, more of people think about that if you have technology, it is going to replace the physician. It's not going to. Technology is there to assist the physician. And if we do not move with the technology, then we may be left behind. So what our aim is, definitely not to replace any clinician. It's just to support, aid, guide. Sometimes you're not sure about what the guidelines would suggest, what level is appropriate, how to do those calculations. The app is meant to help out. And it also specifically tells you where you need to seek a specialist opinion as well. So this is mainly to assist people at all levels. And our studies, if you look at the interpreters for DSD, for diabetes, it may also be helpful not only for the training pediatricians or the pediatricians, but even for endocrinologists and pediatric endocrinologists. So just to ensure that you have a continuous growth, you can just have a look as to what it is suggesting. And then final diagnosis treatment will depend upon, of course, the overall clinical scenario. So we encourage all of you to go and have a look at our MediClasses endocrinology app. It's available both on Android and iOS store. In the first 7 days, it's free for use for everybody. So you can have a look at it. And then it's available for subscription at a nominal fees in terms of the clinical perspective.